Okay, so tonight we're going to talk about the integumentary system, which is vast. It's been forever on it. So what I try to do is go through it and put things in there that I've seen in primary care. I mean, there's some things. The two PowerPoints that are in there for part 1 and part 2 are very good, and I did get some of the things from there that I pulled from there, and they're really good to look at. They went into a couple things that I really haven't seen that often, so I didn't bother to bring them in, but they would be good to look at. So we'll start with this. So the skin, the major function is to keep the body in homeostasis. It's the heaviest single organ in the body, 16% of body weight. There's 3 layers, the epidermis, the dermis, and the subcutaneous tissue. And its function is to prevent fluid loss, provide a barrier, relay sensations, temperature, touch, pain, to regulate the body temperature and the blood pressure, to synthesize of vitamin D, and for excretion of sweat, urea, and lactic acid. This is just a good picture. It shows you the different structures. It shows you the 3 layers. It shows you the hair follicles and the different parts of the skin. It's not something you have to memorize, so don't worry about it, but it's a good picture. And the one, I think it's the part 1, has a second picture of this that shows you a little better. But both of these are really pretty good. Skin appendages, you have hair, consists of the follicle, the shaft, sebaceous glands, and the erector pili muscle. The hair growth cycles have 3 stages. And then nails, you have your fingernails grow at 1/10 of an inch per month, and it takes actually 4 to 6 months to regrow. Toenails take 1 to 1.5 to grow from the cuticle to the tip. So it's important to remember, because if you give any treatments for fingernails or toenails, you need to realize it's not going to be complete in a week. It's going to take a couple months. That's why when they treat fungal nails and stuff, it goes on for a good 4 to 6 months before you actually going to see a total resolution. If you really can get a resolution, usually it will improve somewhat, but it takes a long time. And then you have your sweat glands, which are under the control of the hypothalamus. They regulate the body temperature, water secretion, evaporation, and the apocrine glands, which are located deep in the dermis. In the axilla, the nipple, the areola, the eyelids, the external ears, and the anogenital regions. And secretions are clear and odorless and released under cholinergic and hormonal control. So when they're mixed with bacteria on the surface, that's when secretions produce body odor. Just a little FYI. The different morphologies. So when you see people who come in who have skin issues that are going on, this is what one of the things you're going to look at. For your primary lesions, you're looking at, is it a macule? So it's flat. Discoloration is usually less than 0.5 centimeters. If it's a patch, then the flat discoloration is greater than 0.5 centimeters. So, and there's a picture of there to show you the difference. The papule, if it's elevated, the papule is less than 0.5 centimeters, and a plaque is greater than 0.5 centimeters. Nodules are circumscribed. They're elevated solid lesions that elevated are greater than 0.5 centimeters. A pustule is a circumscribed collection of opaque fluid, and it varies in size. Vesicles are collections of clear fluid, usually less than 0.5 centimeters, whereas a bulla is a collection of clear fluid that is greater than 0.5 centimeters. A wheal or a hive is an edematous transient plaque resulting from infiltration of the dermis with fluid. So it's interesting when you look at all these, because you don't really think about it until you actually see them. A patient comes in with, like a patch of psoriasis or whatever, so that you can actually gauge the sizes and how they do differentiate. Secondary lesions are scales, such as excess dead dermal epidermal cells that are produced by normal keratinization and shedding. And you see secondary lesions like scales in pityriasis, in psoriasis, in tinea, in seborrheic dermatitis, and xerosis, dry skin. So you're going to see all different types of scales there. Crust is a collection of dried serum or cellular debris such as scab. Erosion is a focal loss. Sorry, that should be of the epidermis. And usually, an erosion will heal without scarring. An ulcer is a focal loss. Again, I'm doing too well with my F's. Where was I? Of epidermis and dermis. Ulcers will heal with scarring. And if you think of decubitus ulcers and pressure ulcers, when they heal, they usually have a good scar. A fissure is a linear loss of epidermis and dermis with sharply defined walls. Lichenification is an area of thickened epidermis. It's usually induced by scratching. So any kind of skin disorder that has a lot of itching in it, you'll often see lichenification. You see that a lot in lichens planus. I don't have that in there because I don't see a lot of lichens planus. I've seen it only a couple of times, but you'll see a lot of the lichenification in it. Excoriation is erosion caused by scratching. It's often linear. Special skin lesions, comedones, which is a plug of sebaceous and keratin material. It's lodged in the opening of a hair follicle. Usually, blackheads are open comedones and whiteheads are closed comedones when you look at acne. And I didn't put acne in there. I don't really see a lot of acne, and I only treat basic stuff. Usually, I send them to dermatology, so I didn't really put them in there. But in one of the PowerPoints, they have a really good breakdown of it. Milia is small superficial keratin cysts with no visible opening. Petechiae is a circumscribed deposit of blood which is less than 0.5 centimeters. Purpura is a circumscribed deposit of blood greater than 0.5 centimeters. A burrow, which you see in scabies, is a narrowed, elevated, tortuous channel produced by the parasite. And telangiectasis is dilated superficial blood vessels. You see that in your basal cell carcinomas. And sometimes in your actinic keratosis. Distribution of skin lesions, and you don't have to memorize these. It's just to give you an idea when you see them and you go to describe them. Acral is distal limbs, palms of soles of feet, dermatomal, the nerve root, extensors anterior, posterior, flexural. Intertriginous is where two skin areas meet and rub together. Generalized, scattered, universal, photosensitive, sun-exposed, symmetrical, unilateral, and bilateral. Configuration of lesions, shapes, and arrangements. So you have linear, which you see often in like a poison ivy. Nummular eczema, which they look like little coins. Annular, and you can see candida or tibia are usually annular. Verrucous, warts, and lichenification, scratching. If you look at the hand, you can see the lichenification on the back of the hand. Health history. So when you're doing a health history, you're looking at common symptoms and concerning symptoms. Hair loss. Is it a patch of hair loss? And if it's growing back, is it all growing back at one length? Is it all different lengths? Can you do the pull test on it? If you're pulling, does it come out easily or does it not? Rash, with or without itching. Moles. Have the moles changed? How many moles are there? Do they all look the same? Do they look different? And loss of pigment. Questions, how long have you noticed any changes in your skin, your hair? Have you noticed any moles that have changed in size, color, shape, or sensation? Any new moles? Anything that you're concerned about that's on your skin? So examination of lesions, you want to note the characteristics, the anatomic locations and distribution. You want to know the patterns and shapes and the types of the lesions. Again, are they a macule, a papule, a patch, nevi, vesicles, pustules, what are they? And the color that they are. No, this PowerPoint has not been presented yet. It's not been posted. When I'm done here, I will send it out to everybody so that you have it. So other things that you want to ask onset. Was it sudden or gradual that that the lesion occurred? How long have you had it? Does the patient does it have a single lesion? Does it have a multiple lesion? Is it a small rash? Is it as extensive so that it's on the entire trunk? Where are they located? Like I said, is it confined to a certain area? Um, Herpes zoster is commonly confined to the thoracic and the trigeminal or lumbosacral areas, and it usually follows the dermatome, so it's usually only on one side. Impetigo is often found on the face. Rosacea is usually confined to the middle third of the face. Quality, you want to describe the size, the shape, the elevation, the color of the lesion. Ask, have they had any exudate, any crusting, any pain, any itching? And has the size, shape, elevation, location, or color changed since its onset? So did it start in one area and has it traveled? Has it moved? Has it grown? Such as varicella. Chickenpox usually begins as a red macules and then quickly progresses to papules and vesicles to crust as it goes through its stages. Varicella, rubella, such as German measles, and rubeola usually begin on the face and then they'll spread to the trunk and the extremities. So that's what you want to know. Where did it start and where has it progressed to and how long? You want to ask about associated symptoms. Do they have a fever? Do they have itching? Do they have malaise, headache, chills, anorexia? Fever, malaise, and anorexia are often seen in varicella, and patients with mumps often experience headache, anorexia, and fever. In addition to the rash, patients with rubeola often present with fever, cough, and fatigue. Has the patient experienced any previous malignancy? Has the patient experienced any recent injuries or trauma to the skin? Has they traveled recently outside the country? Have they been exposed to any chemicals? Especially if they come in with a dermatitis. That's the one I always ask them. Any new clothes, any change in soap, shampoos, powder, lotions, anything. What do you do for a job? Especially if it's on the hands. What do you do for a job that could be causing this? Has the patient recently spent any time outdoors? That's the other thing, and been exposed to poison ivy or poison oak. Especially that time is going to be coming up soon. Poison oak coming out and everybody going outside and, working in their lawns and stuff. Is the patient taking any medications? Anything new? Any adverse reactions to drug often manifest with rash. Has the patient eaten any new foods recently? And what have you done to alleviate it? What has aggravated it? Anything? Has the patient taken any medication? Have they applied any topical gels? People are really good about going to Walmart and buying hydrocortisone cream and slathering it all over the place. Any other measures that they're doing? Have they applied heat, cold, anything like that? Because you want to know what they've done and what's worked with them, what hasn't worked with them, and what might have caused it to worsen. Pruritus. Itching follows quite a few of these rashes and skin conditions. It's especially, it's actually a form of pain. And actually, if you think about it, if you have a really bad itch, sometimes you scratch it hurts. Many localized and generalized conditions present with itching. Pruritus is associated with many environmental factors which should be evaluated as potential contributing features. Occasionally, systematic illness may be associated with pruritus. Therefore, a careful history really is important to proceed. And again, the same questions that you're going to ask. The onset, the intensity. Is it worse at night or during the day? And that's important because scabies, usually the itch is worse at night. Ask about, again, the associated symptoms. A rash that occurred either before or after the itching started. Physical exam. You want an examination of the skin, hair, nails, begin with the general survey of the patient. When you do that physical exam, have them take off their clothes and put on a little paper Johnny so that you can really look at their skin. You can always send them to dermatology if you see something that you're not sure of or something that you're finding, somewhat, different or alarming. But you need to get a really good look at their skin before you're going to send them there because they're not going to go to derm until you send them. Make sure they wear a gown and you want to drape them properly and inspect it with really good light, perfectly natural light. However, that's not really easy. Everybody has regular light and most exam rooms do not have windows. I have a dermoscope because I took a dermatology class last semester, so I bought a dermoscope. So if I have anything that I'm really curious about or I want to get a better look at, I will use the dermoscope and I can really see the rash much better. I can see the lesion better. So that works well. But otherwise, you send them to dermatology and they use their dermoscope. You always want to look for your primary lesion and your secondary lesion. So your primary lesion is how did it start? And then your secondary lesion would be what's occurring now. So like the lichenification, what's occurring after. But what should your primary lesion look like if you can do that? The classic rash of scabies includes primary and secondary lesion. That's because of itching. So you have your primary, so you have your burrows, your papules, vesicles, pustules, and then again, like I said, secondary is usually your scratching. You want to note the rash distribution. In infants, the most commonly affected areas are the palms, the soles, the axilla, and the scalp. Involvement of the face is generally uncommon in people older than 5. The only time I've had anybody with something on their face, it's usually like from poison ivy and they touch their face and they spread it, or somebody who's had shingles. And it's usually an elderly person who's a little demented who's touched the shingles and then spread it all over their face. Okay, sorry. In older children and adults, lesions are usually confined below the neck and involve the wet spaces between the fingers, the flexor surfaces of the arms, wrists, axilla, and waistline. Waistline a lot of times is your dermatitis. Nickel, which is in a lot of belts, a lot of times will cause that. The umbilicus, nipples, penis, scrotum can also be affected. So let's get to some of these skin issues. Tinea. Tinea is common. You see tinea a lot. The border is red, scaly, and slightly raised. It refers to a skin infection with a dermatophyte, such as ringworm. They call it ringworm, and not because there's a worm in there, even though people always think there is, because the border is usually raised and does resemble somewhat of a worm. The fungus, depending on which part of the body is affected, is given a specific name. So if it's in the beard, it's Tinea barbae. If it's on the body, it's Tinea corporis. Tinea pedis is athlete's foot. Tinea crus is jack itch. Tinea capitis is in the head. Tinea ungum is the nail. So those are a whole bunch of them. Just so that you know, the head, Tinea capitis in the head, a lot of times you have to use oral medication. A lot of times the creams won't work for that. And tinea for athlete's foot, the one thing to remember is if you treat athlete's foot is to have them put the treatment on and put their socks on and then get dressed with their underwear, okay, and their pants. They always do that first. The other thing is if you have a diabetic and they have a cellulitis, always want to look at their feet to see if they have tinea, athlete's foot, because a lot of times athlete's foot will cause a cellulitis in diabetics. And, you can treat the cellulitis, but if you don't treat the tinea, you're not going to get rid of it. So always look at that. Tinea, you can get them by touching an infected person from damp surfaces such as shower floors or even from a pet. Symptoms depend on the affected area of the body. Ringworm, like I said, is a red skin rash that forms a ring around the normal-looking skin. A worm does not cause it. Usually, when you look at it for tinea, usually they'll have central clearing. So you'll see it's as the mite starts and the fungus starts spreading out, you see the redness and it starts to clear because it's leaving that area. So you have central clearing with the redness around it usually. Athlete foot causes itching, burning, cracked skin between the toes. Scalp ringworm causes itchy red patches on the head and it can even leave bald spots. It usually affects children. You see that more. Jack itch causes an itchy burning rash in the groin. Rodeo kids and wrestlers. Yes, rodeo, that's true. And wrestlers are affected by it. Hypochloric acid water. Oh, really? Oh, that's good to know. Thank you. These are just different pictures of tinea, showing you how it generally looks and where you can get it. Tinea vesicolor, actually I've had quite a few patients with this. It's common superficial infection caused by the organism Pyrrhosorium, whatever, which is a staphylococcus yeast that is part of the normal skin flora. Lesions can be hypopigmented, light brown, or salmon-colored macules. The fine scale is often parent, especially after scraping, and individual lesions are typically small but frequently coalesce, meaning they grow together. And lesions are limited to the outermost layers of the skin. You see it a lot in the warm weather. Most commonly found in the upper trunks and extremities, and less often on the face. In intertriginous areas, that's where I usually see it, is on the trunk and the back. When most people are asymptomatic, some complain of mild itching. The diagnosis is confirmed by microscopic exam. What you can do, even for tinea, you can do it. For regular tinea, you can take one glass slide and you take another one and you scrape the area, and it'll go onto the slide, and then you put your KOH on it. And then you have to let it sit for a little while, or you can heat it up. Either way. Sorry. And then look at it under the microscope. The differential diagnosis includes seborrhea, eczema, pityriasis, and secondary syphilis. So those are all things that you're going to look at. So when you look at it under the microscope, it's when you're going to look for the fungus. Pityriasis rosea, I've only seen this a couple of times. It's common, benign, usually asymptomatic, distinctive, self-limited skin eruption of unknown etiology. It's characterized by the appearance of a slightly inflammatory oval papillosquamous lesion on the trunk and approximate areas of the extremities. I have pictures of it. The eruption commonly begins, and you'll see there's always a herald patch somewhere, which I'll show you a picture of it, or a mother patch. I'll say the one that starts it, and then the other ones are smaller. It's a single round or oval, rather sharply delimited pink or salmon-colored lesion on the chest, neck, or back. It's very itchy. There's some evidence that human herpes virus 6 may be involved. So if they can come in early enough, you can get them started on antiviral. Sometimes it'll lessen or reduce the amount of time that they have it, and it will resolve. Small epidemics have occurred in fraternity houses and military bases. 2% of patients have recurrence. The incidence of disease is higher in winter months. 20% of patients have a recent history of acute infection with fatigue, headache, sore throat, lymphadenitis, and fever. And in pregnancy, pityriasis rosea may foreshadow premature delivery with neonatal hypotonia, which is decreased muscle tone, and even fetal demise, so especially if it develops within 15 weeks of gestation. And here's some pictures. And up there on the left, on the left, up from the umbilicus up to the left corner, you can see the herald patch. The larger one, the larger lesion, that's your herald patch. So that's usually what you look for in it. And then the bottom, sometimes they have what they call a Christmas tree pattern, and that's what the back is supposed to be looking like. And there's a herald patch in there too. It's hard to see from this picture, but the eruption spreads centrifugally or from the top down in just a few days. The long axis of these ovals tend to be oriented along the lines of the cleavage of the skin. So like I said, it usually comes out like a pattern. And they fade without any residual scarring, but it can be very itchy. Acne rosacea is an acneiform disorder of middle-aged and older adults. You see this an awful lot. It's characterized by vascular dilatation of the central face, including the nose, cheek, eyelids, and forehead. And the cause is unknown, but it's chronic. Usually once they have, it's really hard to get rid of. At least I found it hard to get rid of. It's a chronic disorder characterized by periods of exacerbation and remission. It's increased susceptibility to recurrent flushing reactions that may be provoked by a variety of stimuli, including hot or spicy foods, drinking alcohol, temperature extremes, and emotional reactions. In the earliest stages, is characterized by facial erythema and telangiectasis. And this is picture. And it's kind of weird because you always think of, she almost has like a butterfly rash, which you think of in lupus. So lupus would be part of your differential. So the diagnosis is based upon clinical findings, one or more of the following: flushing, which is a transient erythema, non-transient erythema, papules and pustules, and telangiectasis. And it may develop severe sebaceous gland growth that is accompanied by pustules, papules, cysts, and nodules. So they almost get like a severe acne too along with it. Eczema is the most common inflammatory skin disease. Recognizing a rash as eczematous rather than psoriasis or lichenified is really an importance of effectively diagnosing a skin disease so that you can treat it, even though some of the treatments are similar. You want to look carefully at the rash to determine the primary lesion and then look for your secondary lesion for an infection or irritation. And there's usually 3 stages to eczema. You have the acute stage where you get vesicles, blisters, intense redness, and intense itch. You get subacute where you get redness and then scaling, fissuring, parched or scalded appearance, slight moderate itch, pain, stinging, and burning, and chronic, which is like a thickened skin, so you have a lichenification, excoriations, fissuring, and moderate to intense itch. And these are just pictures of eczema. And in older children and adults, eczema appears less often on the face and more commonly on the hands, neck, inner elbows, back of knees, and ankles. In younger children, eczema usually appears on the face, elbows, knees, and possibly other areas. So you see the little baby with his eczema on his face. And also, if people are older and they have eczema, you should ask them, a lot of times they had asthma as children. So I have a case study for you. A 27-year-old female presents with a distinct, raised, circular red rash with a scaly border and clearing center on inner aspect of the left thigh, distal to the inguinal area. She provides a history of going to the gym and showering after in the public showers. She denies pain and admits to itchy feeling around the lesion. She's not applied any over-the-counter medications. Her vitals are normal. So what else do you want to ask her? How long she's had it? Yep. Anything else? Anything make it worse or better? Ever had it before? Yes. Okay, good. So after assessing the rest of the body of similar lesions, what do you think this is? Yep. Any fever? Yep. Ringworm. Yep. So you think so you're calling it a tinea. And remember, you're looking at it. It's distinct raised, circular red lesion with a scaly border and central clearing. Okay. All right, so psoriasis now is a common chronic skin disorder typically characterized by an erythematous papules, so reddish papules with plaques, with usually a silver scale. Most of the clinical features of psoriasis develop a secondary response triggered by T lymphocytes in the skin. Nail psoriasis, and I've only seen nail psoriasis twice, but they can get it there. Typical nail abnormality in psoriasis, you can see pitting, and I have a picture of it, pitting with color changes and crumbling of the nails. Other clinical features, you have different types. You have plaque psoriasis, which is symmetrical distribution plaques that involve the scalp, extensor, elbows, knees, and back. You have guttate psoriasis, which is an abrupt appearance of multiple small psoriatic lesions. They almost look like drops, teardrops or raindrops. And usually that'll follow a viral infection. And then once you get that, then you have psoriasis. Pustular psoriasis is the most severe form of psoriasis, characterized by redness, scaling, and sheets of superficial pustules with erosions. And then inverse psoriasis refers to the present. So you can get psoriasis in your axilla. Remember, interdigenous is when two skin areas touch each other. So under your breast, in your axilla, are all good areas to get like a psoriasis. Okay, so these are your pictures. So here's your somewhat silvery on your knees. This is your nails. It's not the best picture of your nails. I've seen them crumbling and worse, but this is that's how a lot of times they'll present. You can have it at the back of your head. The one in the middle of the bottom is your guttate psoriasis, and that's your interdigenous. The one to the right of it, the small one, the armpit, is your interdigenous psoriasis, your inverse psoriasis, call it. So a 26-year-old male presents to your office with complaints of a rash on his face, across the bridge of his nose, and upper cheeks. He reports his mother had this as well, but she did not know what it was called. And when you examine the patient closely, you see a widespread convoluent, so it's coming together, erythematous facial rash of the upper cheeks, including the nose. That is a combination of papules and pustules, but no comedones. So there's no acne so much there. So what other questions are you going to ask them? Anybody? What makes it worse? What makes it better? Okay, allergies. Have you ever had it before? Onset? Yes. The different. So it would probably be a rosacea. Fever. What aggravates it? How long? Yep. 41-year-old male presents with dry, silvery, scaly plaques-like lesions on red, inflamed base. The lesions are located on the knees and elbows, and after doing a whole lot body assessment, observed that these lesions are confined to the exterior surfaces of the extremities. So, again, this is most likely what? Psoriasis, yeah. And it does run in families, okay? So you want to know that, too, if they have a history of it. Plaque psoriasis? Yes. Dermatitis. Contact dermatitis refers to any dermatitis arising from direct skin exposure to a substance. It could be allergic or irritant. An allergen induces an immune response while an irritant directly damages the skin. So most common would be poison ivy, poison oak, and poison sumac, and now is the time that that's going to be starting. Other common sensitizers in the U.S., like I said, nickel, jewelry, belt buckles are really big on that. Formaldehyde, clothing, nail polish, fragrances, perfumes, cosmetics, preservatives, topical medications, rubber, chemicals in shoes, leather and synthetic. These are different pictures of allergic contact dermatitis. This is a little baby. Their finger toes probably be a chemical one. The one on the bottom, maybe a new pair of shoes. And then the one next to it would be, see where his belt rubs against his abdomen? Fake gold, yep. Cellulitis, it's an infection of the skin with some extension into the subcutaneous tissue. Extremity is the most common location, but any involved area of the body can be involved. Legs are really big on cellulitis. I had a man, his thumb, he didn't even come into me for that. I forget what he came into me for. I was doing an examination of him. I just happened to look at his thumb. I said, it was like, you should have seen it. It was like 5 times the size. It was bright red. It had to hurt like heck. And he said to me, oh yeah, he cut it somehow, and it like a week or so before that. But it never even occurred to him to tell me that he had problems with his thumb when he was here. I forget, it was something really ridiculous that he came in for. So we got his thumb treated and taken care of. Independent risk factors: lymphedema, site of entry, leg ulcer, traumatic wound. Traumatic wounds are really big, especially in the elderly. They're always banging their legs on something or tripping and hurt, and they end up with the cellulitis. Venous insufficiency, leg edema, and being overweight. Adult diapers. Okay, any recent surgery? Yeah. Yep. And like diabetes. Remember, diabetes, if it's out of control, they have infections that just run rampant. UTI, cellulitis, you name it, they get it very easily. Has both local and systemic features, such as fever and chills, myalgia, increased white blood cell count. You want to check for lymph nodes too. If you think there's a cellulitis, you want to check their lymph nodes to see if they're enlarged. Local findings typical of cellulitis: macular erythema that is largely confluent, generalized swelling of the involved area, warm to the touch, tenderness to the affected area. Again, the lymph nodes, you want to check them because they're usually tender. And abscess formation may also be present, depending on what causes cellulitis. And this is just a periorbital cellulitis, one of the hand and then one of the foot. And you can see on the hand and the foot, they each have a wound, which started it. Scabies is an itchy, highly contagious skin condition caused by a mite. Uh, it's very hard to actually, if you do a scraping to see if somebody has scabies, it's not, you don't always get that mite. Sometimes you're lucky and you'll actually get in and you can see it under the microscope, but it's not often. You want to look for the burrow. You want to look for, is it traveling in a line? And that's where the dermoscopes are really good because you can really get in there to look. But even if you shine a light and really get down there and look, you can see, you can look for the tracking. The scabies mite burrows into the upper layer of the skin where it lives and lays its eggs. The most common symptoms of scabies are intense itching and pimple-like skin rash. And let me tell you, the itching is really bad. And like I said, a lot of times the nighttime itch is a lot worse. It's usually spread by direct contact, prolonged skin-to-skin contact with the person who has scabies. After the mite burrows into the skin, it takes time to develop signs and symptoms. So if the person has had scabies before, the itching usually begins within 1 to 4 days. When the person has not had scabies, the body needs time to develop a reaction to the mite. So it might take 2 to 6 weeks to develop the scabies. I work at Western Mass Hospital, and we got a patient a couple years ago with this rash all over his body. And he came from a long-term care facility. And dermatology had treated him. He had creams like up the wazoo, like we would not believe. And so we decided to do a scraping, and actually we did the scraping and actually got the mite, which is really rare. And so he got treated, but unfortunately so did all the 14 other people on the floor that had to be treated. But we had to treat him twice, and we had to give him the oral medication in order to get rid of it because the cream was not doing it. So once we gave him the oral medication, we gave him a 2-step one. It got rid of it, and he hasn't had it since. So scabies the severest can lead to constant scratching. With no stop scratching, an infection can develop. So you have to really be careful. And then you can get sepsis, and then they can really get in trouble. Scabies can develop anywhere on the skin. The mites, however, prefer to burrow in on certain parts of the body. Most common places are the hands. Mites like to burrow, especially in the webs. You want to look in the web parts of their fingers, and a lot of times you'll see the burrows from there. Arms, mites like the elbows and the wrists, and skin usually covered by jewelry or clothing. Buttocks, belt line, penis, skin around the nipples, it's pretty much everywhere, are likely places. Mites also like to burrow in skin covered by bracelets, so watch bands or ring because it's dark and warm. So Norwegian-crusted scabies is kind of a, you don't see it quite as often. You get crusted lesions, scaly plaques located mainly on the hands, feet, scalp, and under pressure-bearing areas. They, let's see, they can be infected with hundreds to millions of adult female mites. And as a result, this type of scabies is highly contagious and may spread rapidly through patients in an institutionalized setting. I've seen that only one other time besides this man. And this is just a picture. If you look over to the right, the big picture, you can see the tracking in the burrows. And then the hand, when you see it, you can see a little bit of tracking if you look real close. And then the bottom is just a full body. Herpes zoster is a reactivation of latent varicella infection within the sensory ganglia, results in herpes zoster or shingles. It's characterized by painful unilateral vesicle eruption in a restricted dermatomal distribution. So usually a lot of times they'll start with burning, and then the rash will start after that. I know my sister had it, and she's a nun. She's a sister of St. Joseph, and she shares an apartment with 2 other sisters. And she had gotten up one morning, and she said to one of the other sisters, "Can you look at my back?" She said, "It burns and it hurts so bad, and I don't know what's going on." And she had shingles back there. I've had people come in with it down the back of their head where they didn't realize it, but they were just having pain in their head. And I had a man who came in with it. It was I've never seen anything that bad before. It was the whole left side of his head, forehead, face. And my biggest fear was that it was in his eye and he was going to go blind. So as soon as I was done with him, I shipped him off to the eye doctor so they could check his eye, and his eye had been fine. But it was just unbelievable. The virus emerges from latency. Nobody really knows why. I know a lot of times they say stress brings it on. Patients frequently experience a prodrome of fever, pain, malaise, headache, precedes the vesicular dermatomal eruption by several days. And they need to get in there, and you need to treat them at least within 72 hours. I had a lady, she came in 12 days later. It had almost run its course by the time I got it. And she didn't come in because she said she knew she had an appointment coming up, so she decided to wait. She didn't know what was wrong with her. She was just having pain and burning in her head. And it was when I was looking, trying to see what was wrong, is when I found the shingles. And like I said, it was almost finished. The rash initially appears along the dermatomes as grouped vesicles or bulli, which evolve into pustules or occasional hemorrhagic lesions within 3 to 4 days. The thoracic and lumbar dermatomes are the most commonly involved sites. And remember, it's usually only on one side of the body. If you see it on the other side of the body, it's because they've touched it and probably spread it. So usually you tell those patients, you can't touch it. If they do touch it, they have to wash their hands immediately before they touch anything else. The complications of herpes zoster include ocular, neurologic, bacterial superinfections of the skin, and postherpetic neuralgia. Some people get the postherpetic neuralgia, some people don't. We use gabapentin usually if they're having the pain, and a lot of times that'll help. You can also use low-dose TCAs too, but I don't do that too often. Usually I use the gabapentin. And this is just a picture of herpes zoster. This lady that's exactly what the man looked like. It was unbelievable. It was just crust upon crust. It was just disgusting. I felt bad for him. All right, so case study. A 50-year-old truck driver presents to your office with complaints of intense itching over the past 3 weeks. He has applied over-the-counter hydrocortisone. It stops itching for a while, but it comes back, and he also reports some redness. The condition is getting worse, especially at night, and the itching keeps him awake. He tells you that he stays in motels when he's traveling on his truck route. He's divorced. He does not work outside or in the yard. And he denies allergies or asthma or taking any medications other than cortisone. You examine him, you find numerous erythematous papules, vesicles, encrusted burrow-like areas in linear distribution along the outer aspects of his arms and legs. So what do you think? Scabies, yes, very good. A 66-year-old female presents to your office with complaints of pain in her back. It began 2 days ago. She denies history of pain like this in the past. She said her skin hurts to just touch it. Can't even stand the sheets touching her skin. She denies injury. She does or doing anything straining or straining her back or lifting objects. Upon questioning her further, you learn she has diabetes, and she also has a diagnosis of cancer of the colon in the past year. So upon exam of the patient, you find, yes, I see herpes zoster. Very good. Find small vesicles, linear manner on the right side of her thorax. Very good. All right, we're almost finished here. Skin cancer. Most common form of cancer in the United States, more than 1 million new cases annually, increasing incidence. Most common is basal cell, followed by squamous cell carcinoma, and then malignant melanoma. When I was a kid, my mother used to say to us, "Oh, go outside and get color." I have many sunburns from those years. So actinic keratosis or solar keratosis, they're pre-malignant lesions that develop only on sun-damaged skin. They appear as patches or hyperkeratosis with some surrounding erythema on sun-exposed areas of the head and neck, forearms, hands, and upper back. You see it a lot, especially men who are bald. You see it on the top of their head. Actinic keratosis is a squamous cell carcinoma and is confined to the epidermis. I see these quite a bit, and I send them off to dermatology to be treated. Scaly or crusty growths caused by damage from the sun's UV rays. They typically appear, like I said, on sun-exposed faces, bald heads, scalps, lips, the back of the hands. are often elevated, rough in texture, and resemble warts. Most become red, but some will tan, pink, red, or flesh tone colors. So this is pretty much what they look like. The one over to the right, the picture, is a bald man who has quite a few of them on his forehead, on his head, and they use either 5-FU or imiquimod to treat that usually. And then these are single ones. I've seen a lot of the bald men with it. I see the one on the left, and like I said, I've just sent them off to dermatology to be tested, to be evaluated, and treated as needed. So skin cancer risk factors: male greater than 50 years of age, personal history of skin cancer, blue or green eyes, continuous exposure to sun at work or play, blonde or red hair, light skin that burns, freckles, or gets red, family history of skin cancer in certain types, and large amounts of moles. This is the Fitzpatrick skin type classification. This is really a good thing to remember because when you're charting on your patients, especially a skin thing, this is a good thing to put in there what type they are. So type 1 always burns, never tans. That's me. Type 2 usually burns, tans minimally. Type 3 burns moderately, tans gradually. Type 4 burns rarely, tans readily. Type 5 rarely burns, but tans profusely. And type 6 never burns. So basal cell carcinoma, or 80% of skin cancers, are usually they're shiny, translucent, and they go slowly, and they rarely metastasize. Squamous cells are 16%. Skin cancer, crusted, scaly, ulcerated, and they can metabolize to quite a few different organs. And melanoma, 4% skin cancer, rapidly increasing in frequency and spreads very rapidly. My husband had a melanoma several years ago. It was funny because it was on a really weird place. It was on the side of his ankle. And I dropped something one day, and I bent down and picked it up, and he just happened to be standing there. And I said to him, "Wow, you have a classic melanoma." I said, "You need to go to the doctors." So he went, and they had to take out a huge amount from his ankle and do and they shot dye through to see what lymph nodes had to be removed and stuff, and they had to do skin grafting. And he's been fine ever since. But it was a good size one. And his ankle is the last place I would ever thought. But you know, he spent his childhood. His parents had a house down at Cape Hatteras, so he would be down there all summer long. I'm sure he was barefoot in his bathing suit all the day. So you know, he's Italian, so it's not like he's even Irish. He's Italian, so he gets dark when he goes out in the sun. He might get a little sunburn, but nothing much, and then he darkens up. So basal cell carcinoma begins as small shiny nodules and grows slowly. It's the most common form. Frequently, the central portion breaks down to form an ulcer with a reddish purple scab, and the tumors usually remain fairly localized and rarely spread elsewhere. And a lot of times you'll see like a telangiectasis, like little spider veins coming out. I'm not showing it so much here, but sometimes you'll see that. I see it a lot on the nose is where I've seen it, and I send them to dermatology, and they've done the Mohs procedure, where it's extensive. It's this procedure that they do where they take so much off, they look under the microscope, and they keep going until they have clear margins. So they're there for a while having it done. But like I said, I've had 3 people that I sent. It's all been on their noses, and they've all had the Mohs procedure to have it removed. Basal cell, the cancer usually does not spread to other organs, but if neglected, it will continue to eat away and grow beneath the skin. It's kind of like a tip of an iceberg where you have small cancers may have a lot more beneath the surface than what you're actually seeing, and that's an important thing to tell your patient, that this is what we're seeing, but I don't know what's underneath it. And that's why you need to go to dermatology and have it evaluated. Neglected cases can result in severe disfigurement. In a very rare case, if the cancer has grown large enough, it can cause death. And the cure rate is very good for basal cell carcinomas, better than 90% with the first treatment. Squamous cell carcinomas may grow rapidly or slowly. A wide range of metastasis, metastatic potential depending on the lesion size and the location. Lesions on the face, including the lip, ear, mask area greater than 2 centimeters in diameter, have the greatest risk of metastasis, and typically appears as a papule or a plaque that becomes ulcerated and weeps, like a sore that doesn't heal. It's another common form of skin cancer. When these tumors first appear, they are firm to touch. They appear most often on sun-exposed areas. They evolve very slowly through a premalignant stage, like I said earlier, as the actinic keratosis. And untreated, significant numbers of these lesions can metastasize to different sites. Tumors on the lower lip and ear are at higher risk to spread. And these are just pictures of squamous cell carcinoma. I had somebody once who had one on her face, and actually when they went in to do the surgery and stuff, it was quite extensive. It was not, what we saw wasn't even close to what they found underneath they had to remove. She was really quite disfigured when they were done. Melanoma is the most dangerous form of skin cancer. These cancerous growths develop when unrepaired DNA damage to the skin cells, usually by ultraviolet light. Ultraviolet light causes all of them. Radiation from sunshine or tanning beds. And that's the other thing. I always talk to the young people that come in and try to discourage them from tanning beds because they think tanning beds aren't going to do anything, are going to hurt them. It triggers mutations that lead the skin cells to multiply rapidly and form malignant tumors. They originate in the pigment-producing melanocytes in the basal layer of the epidermis, and the melanomas often resemble moles. Some develop from moles, and the majority of them are black or brown, but they can also be different colors. They can be pink, red, purple, blue, or white. So anytime you see two-tone moles, odd-shaped moles, or moles with other colors other than the brown or that have pink or red or something in it, you always want to send them off to derm. Okay, let's see. I already said that. Melanoma kills an estimated 8,790 people annually in the United States. If melanoma is recognized and treated early, it's almost always curable, but if it's not, the cancer can cause advance and spread to other parts of the body where it can be really, really hard to treat and be fatal. So what are the risk factors for melanoma? Greater than or equal to 50 common moles. Some people, it's really weird, some people just have tons and tons of moles on their body, and other people have a couple here, there, or none. My husband has quite a few moles, and his grandmother, she had tons of moles. And so he goes to the dermatologist. He used to go every 3 months, but he goes every 6 months now. And usually every time he goes, he comes home with a couple more moles removed. Greater than 1 to 4 atypical or unusual moles. Caucasian white ancestry, fair skin, light hair, and light colored eyes, which really should be me and not him. Actinic antiguities, which are macular brown or tan spots, usually on sun-exposed areas. Heavy sun exposure, and family history of melanoma. Screening, we all know the screening, the ABCDs, asymmetry, irregular borders, especially ragged, notched, or blurred. Change in color, especially blue or black. Diameter greater than 6 millimeters or different from others. And that's the other thing to look at. You're looking at your moles. Do they all look the same? Do they all look the same except this one that looks totally different? That's the one that you're going to send them to have a look at. Okay? If they all look the same, it's not that you can't send them to derm, but they all look the same. A lot of times they're most likely pretty benign, but then you get that one that's totally different from the others. It's either different shapes, it's two-toned. There's something different about it that stands out that you want to have it looked at. Elevation or enlargement. And this just shows you your asymmetry, your border regularity, your color change, and your diameter. And the thing of it is, too, when you look at your mole, even if it's kind of a little odd-shaped, what you want to look at is if you fold it in half, do they match? Would it match when I fold it in half? Or if I fold it in half, is it totally different on one side than the other side? So there's a lot of things to look at. Again, we're not going to treat them, but you're going to look at them and you're going to say, all right, I need to send you to dermatology so that they can really check this out and biopsy it. So this is a 70-year-old male farmer who presents to your office for a yearly exam. During the course of the visit, you notice a lesion on his face. He reports that it appeared at the end of last summer. He thought it was just a sunburn and it would go away, but actually it's gotten bigger. He He denies any pain or any occurrence of such lesions in the past. He doesn't use anything on it. It does not bleed, and when you observe the lesion closely, you find that it's located on the side of his face, close to his nose. Yes, they do, because melanoma and squamous cell, I believe, can go into your eyes, so that's why they do that. So what do you think this is? Basal cell. Yep. Very good. Okay, that's the end. Like in a nutshell, let me tell you, there was just so many things, but I'm not gonna. I inundated your brain enough as it is with this. So what I wanted to tell you was, so our quiz is Monday. It is on the abdomen and it is on this. I will send this PowerPoint to everybody as soon as I'm done here tonight. I'm trying to think what I was going to tell you. So it'll be 6 questions from the abdomen, 6 questions from this. I'm not going to have lockdown respondents on it. I did finally get an answer from them. Somebody went in and took the quiz, and they said that they had no problems. So they said they're wondering if maybe there's a few things. What was it now? I just lost it. Well, they sent me all the stuff, and I'll send it to all you, and I'll explain it a little better in my note that you have to look at on your computer to make sure that your operating systems and everything are the right ones, because they said they went in and they didn't have a problem. So I'm not going to put it on this week because I want you to study for the quiz. I will put on information so that you can go in and check things out, and then we'll go from there, okay? The abdomen PowerPoint, I sent it out to everybody, and it's posted. It's under Abdomen WIMBA class, I believe. But I sent it out to everybody last week, and it is posted under that week's with the PowerPoint. It is under there. So if you don't have it, let me know, and I'll send it again. Yes, it's posted last week. I can't think of anything else. There was something else I wanted to tell you, but I can't remember what it is now. I don't know. Kathleen, is there anything else?
No, I'm just so impressed with all I know about the skin now. Thank you.
The skin is, I'm telling you, people come in, I have that thing, and they'll say they have a rash, and it's like, oh my God. I bring my germ book in. Whenever I have something with a rash and I'm not sure what it is, I bring my germ book into the room and I look at it. And I go from there. And usually I can find it in my derm book that'll help me.
I have a great derm book, and I have great pictures. Just wanted to tell people, I think it's Gainesville has a dermatology DP program, and they talk about the dermoscope. In Florida, I live in Alabama, and nurse practitioners do not get hired by dermatologists because they can't give Botox and they can't do lesions. So all the dermatologists hire PAs down here. But in Florida, nurse practitioners are smart enough to get that PhD, and they're everywhere in Florida. And, you know, derm is a cash basis. So those dermatologists, NPs, make big bucks in the state of Florida. But if you're working in a place, it's nice to have a dermoscope. And even though Ellen and I consistently talk about sending people to dermatologists, not everybody can afford to do that. I recently had something done at the dermatologist, and they write on the wall, it says you're going to get 3 bills. One for the procedure, one from the pathologist, and then one from the office. And so if you have any kind of copay, you can go to a dermatologist and you can spend lots of money. My husband had the Mohs, I've had the Mohs, and that was close to $5,000. So it's very expensive, and you have to know that before you send somebody to a dermatologist. Don't you agree? How much did it cost for your husband's surgery for melanoma, Ellen?
Oh, I don't even know. It was so many years ago, I don't remember, but between the plastic surgeon and the hospital and the anesthesia and the dye, it was like, luckily his insurance paid for the majority of it. But
And so even though we talk about, I think the most important thing about skin is that even though you talk about those genetic factors, that doesn't always work for people with skin cancer. We talk about, now they talk about sunblock actually does make a difference, but it's the goal of lack of sun exposure between 10 and 2, not sun exposure with sunblock. And there's a huge difference. And now they're saying up to the age of 21, if you keep them from having sun exposure, then you've given them the rest of their life without skin disorders. But after age 21, sunblock makes little difference because those skin cancers take forever to grow and appear. And keep in mind, on black people, they have melanoma on the soles of their feet and under their toenails and fingernails. So that's important. So I'll put them in the breakout room. Ellen, did you have anything else to say?
No, that was it. Thank you.
Okay, it takes me a moment, and I know you people go back and forth in this breakout room, not because you want to, just because it happens.
Oh, you know what I wanted to tell everybody is next week's class. We won't have a class. I will archive the lecture so that you can come on and listen as you can. So I'm not going to do the class, but it'll be there for you to listen to, and I will send everybody else. I'll send everybody else a PowerPoint.